This is the first part of physical examination of the newborn, about examination of newborn's skull. The skull might be molded when the head has been engaged in the pelvic canal for a considerable time. Caput succedanum is caused by skull pressure from the uterus, cervix, or pelvis. It appears as a circular boggy area of edema with indistinct borders and often with overlying ecchymosis. And also we should have to check for cephalohematoma, which presents as a well-circumscribed fluid or blade-filled mass that does not cross the suture lines. Unlike caput succedanum, cephalohematoma is often not present at delivery. As its name shows, it is hematoma. It develops slowly, but it develops over the first few hours of life. The other thing that we should have to check is subgaleal hematoma. Subgaleal hematoma occurs when blood accumulates between the periosteum and the aponeurosis due to the tearing of emissionary veins. It is not restricted by the boundaries of the sutures and therefore is larger and more diffuse. Unlike that of cephalohematoma and the caput succedanum, subgaleal hematoma is not restricted to a suture line. It's a diffuse hemorrhage from the anterior fontanelle, from the forehead up to the nape of the neck. It requires prompt recognition because extensive bleeding might result in hypovolemic shock with estimated mortality up to 20%. The head circumference of all newborns should be plotted on a gross chart to identify an excessively small head or macrocephaly or excessively large head, which is megalencephaly. The suture lines and the size and the fullness of the anterior and the posterior fontanelles should be determined digitally by palpation. Great variation in the size of the fontanelles exists at birth. If small, the anterior fontanelle usually tend to large during the first few months after birth. The persistence of excessively large anterior and posterior fontanelle has been associated with several disorders. Premature fusion of sutures, cranial synostosis, is identified as a hard, non-movable ridge over the suture and abnormally shaped skull. Persistently small fontanelles suggest microcephaly, craniosynostosis, congenital hyperthyroidism, or Wormian bones. Persistence of a third fontanelle suggests trisomy 21, but seen in premature infantes. Soft areas, which we call it craniotapes, are more common in preterm infantes and in infantes who have been exposed to uterine compression. Most of the time, this is a benign condition, but possible pathologic cause should be investigated if they persist, such as rickets. Atrophic or allopathic scalp areas might represent aplasia cutis congenita, which may be sporadic or autosomal dominant or associated with trisomy 13 or chromosome 4 deletion. We should have to also check for deformational plagiocephaly. This might be the result of in utero positioning force on the skull and manifest as an asymmetric skull and the face with ear malalignment. It is associated with torticollis and the vertex position sometimes. Thank you for watching. On the next episode, we'll see the examination of face, neck, nose, and the mouth of newborn.